Our next speaker is known to most of you because he's about the only man in the world doing the Nagelase test, which is, of course, really important. So he, of course, is mentioned on the front page of our website because those of you who need Nagelase tests need to go to him. And we are very much hoping that the turnaround will improve, and we are trying to help him to improve the turnaround. So, Doctor, we've had Nagelase, by the way, we've had quite a bit of controversy because some people say they won't do it without Nagelase, but others do. So it's very much your choice. But from our point of view, it's absolutely wonderful if you've got the data. Dr. Vogelar.
It's less than 1% than the ones you can save by improving your vitamin D. And if you are afraid for vitamin D or the sunshine and that, you know, in the food there's nothing. 10% of your vitamin D you can get from the food, unless you eat 5 herrings a day or something like that. Yes, nobody does that. And then, you know, prudent sunshine. Yes, 5 to 15 minutes at noontime is the best, if there is sun, of course. And, or if you don't like the sun and you cannot tolerate the sun, you can take a supplement. 25 micrograms is 1,000 units, and you can reach optimal levels of vitamin D. And most people don't have optimal levels today. I come to that later. You can save a lot of money in Europe, you see. It's something for the big bank of Europe, here in Frankfurt, I think. This is the way to do. Give everybody a little bit vitamin D. 50 micrograms a day, and you can save a lot of money. And cancer is only one part of it. Now, cancer and vitamin D, if you go to levels and studies, here are 4 studies. If you have levels above 82, then you can reduce your colon cancer frequency with 50%. These are the totals of the studies. And here, if you take extra vitamin D, 25 microgram, indicates 14 studies and 8,000 cases controlled to 340,000 controls. You see there's 50% reduction on the colon cancer. That is prevention, yeah? Mainly prevention. And here you see the strange thing. In Europe, we think Spain is full of sun, and Germany not so much, and Holland not so much. But we have higher levels than the Spanish people. And in Norway, even more pronounced. You see here, no sunshine, but so what do? What's happening? These people in Norway, they eat cod liver, oil, yes, they still take it a lot. And in Spain, they never go sitting in the sun, they sit inside. So, and it's only some stupid people from the north stay in the sun there. And so this is Europe, but if you go to the Middle East and Asia, there's more deficiency even. Yes? And of course, in Canada, you can also save a lot of money with vitamin D if you increase the levels. This is vitamin D. It's not only boosting the immune system, but also inhibiting the immune system. You know, the yellow things are inhibiting. For example, here, autoantibodies, yes, you make less. That's good, I think. And the green ones is enhancement of the immune system by vitamin D. Now we come to the dehydroxyvitamin D that you can make yourself through the kidney, for example, but also organs can do that. This is the active factor, they think, not the vitamin D. There's only one hydroxy. You see it has a lot of anti-cancer actions. So it reduces angiogenesis and metastasis, inhibits inflammation, and things like that. So this is very important, and also a combination with other anti-cancer agents, such as vitamins, vitamin A, things. I missed it in one of the speakers this morning, vitamin A. It seems to be, was in the past at least, the normal therapy for cancer in Austria. And you see there is, I think, better to give A and D optimal to boost your immune system. Now we come to the famous, I can go quick now, GC protein or vitamin D binding protein. Vitamin D is bound to it. It binds also other substances like the dehydroxy, the vitamin D, and the actin, and more. the half-life of this protein is 2.5 days. And patients with multiple organ dysfunction have lower levels and have higher risk of dying after that. And the serum levels of DBP correlates with the dehydroxyvitamin D a little bit. You see 0.26, significant, but not with the normal vitamin D. And both vitamin D correlate with each other. That's what's happening, but not much known about that. This protein has important physiological functions. So I spoke about vitamin D transport, but it's also saving the actin, and then it enhances the chemotactic complement 5 factor, very significant and sensitive, as far as I know. And it's also doing its job through the GcMaf. That's why they are for here, yes? And vitamin D is bound to the amino thermal end of DPG and actin to the other side. If you want to see it a little bit more in detail, we have seen it before here. Here we have the sugar, here we have vitamin D binding site, here we have the actin binding site. But now I go a little bit more in detail to the different forms of the GC. Yeah, you see 1F and 1S and GC2 phenotypes, yes, and they give other amino acids in the protein, just a few sugars in the DNA different. And then you see different chains. Here you see the famous substance we spoke about already all the time, but there's another form where there's mannose here, and there's another form where there's only 2 sugars. And they can all be converted, in principle, to the GcMaf. But the story is not so easy, so not one sugar chain is a little bit complicated, but this one is the most prominent, yes? And okay. It's also a hepatic acute phase reactant, DBP, and it's upregulated in patients with all kinds of diseases, including certain cancers and Alzheimer. And it's downregulated also in other diseases, so it can be upregulated and downregulated. And it plays a role in the immune modulation directly through the GcMaf and indirectly by influencing serum vitamin D levels. Okay, now we come to the therapy with the GcMaf. The vitamin GC loses 2 sugars in principle, and if you give these patients the therapy with GcMaf for 14 to 50 weeks, you can get normal levels if you do it correctly, and Nagel's is considered to relate to the tumor burden. The total dose for therapy is 1 to 5 microgram in general. That's almost nothing, yes? And there are hardly no side effects, almost nothing. And that is what Yamamoto found, no recurrence of the disease for 4 to 7 years. But now I go back to the sugars, yes? The sugars on this protein is galactose and N-acetyl galactose and sialic acid. And they are so-called factoring the essential sugars on the outside of membranes or proteins. Here, for example, you see a protein, yes, with 1 sugar, and then you see there's another sugar attached to it when it's formed, yes, in the body. And then there's another sugar. This is what, like, more or less GcMaf structure is, but you can have much more sugars too. And so that is what, how you make these proteins in the body. You make it, first the DNA, you make your protein sequence, and then you attach some sugars to it. Okay, cancer and sugars is a very important subject because they change the glycosylation, causing loss or expression of certain structures, and it's a universal mark of the cancer cells to do this, yes? And certain sugar structures are own markers of tumor progression. Or opposite, this GcMaf. Well, in nutritional science you see that many of the sugars also have a function against cancer. Galactose inhibits tumor overgrowth, yes, and you have to eat a lot, but maybe it is binding in agarose partly, so it's less effective, yeah? I don't know what it is, but, and here you see acetyl inhibits tumor growth too. So we have to study a lot more, I think, if we go on these sugars. The nagalase, okay. The production is seen in cancer and certain virus infections like HIV, but also influenza, Sendai, measles, rubella, and maybe other ones. Nonetheless, inhibits the production of GcMaf, and it stimulates the macrophage for a long time, GcMaf. So the half-time is 6 days, if it's stimulated, yes, the macrophage. But you can also have deficiency in the Schindler or Kansanki disease of this enzyme. So that's not good, but that's a different kind of research. Nonetheless, and cancers, yes. In addition to the prostate, breast, and colon cancer, it has been detected in many other cases of cancer too. You see a lot of them. It was by the first 420 patients they researched. This article about 1998. And it's the good thing, very interesting thing, Nagalas is increased already below the detection levels of other diagnostic methods. Yeah, so it's a very sensitive method. So as with X-rays, for example, you don't see so much. Well, this is the functioning, we discussed that already. And Nagalas seems to do this effect, taking away all the sugars immediately, but that's not 100% clear. I have some other picture here. They say the Nagalas is taking it away at the end, so before it can do its job. So, and they did some studies here with it. They added to control and then LPS, and then GcMaf. You see that is both active, yes. And then if you add a lysate of cancer cells to it, you see it's going down, the effect. And if you do Nagalase to it, it goes further down, yes. So this is some in vitro test you can do. Okay, the DPG and the sugar taking off leads to immunodepression in the cancer patients, and in all 52 cancer patients there was an increase of Nagalase levels in the tumor, and here's an example of it, yes, you see. Here this is healthy plasma, you don't see any Nagalase. The black is the Nagalas, yes. The patient serum or plasma is already increased, but if you look at tumors, yes, it's much more increased. So tumor, the concentration is much higher than in the plasma of the cancer cell. And this is the other one is just the control glucose gas. Okay, this is 46 oral cancer patients and Nagalase, and so they have all increased levels, and the normal levels is here presented. But here you see, if you do operation, what's happening then. For some patient, they did operation, and you see 2 weeks after the operation, 3 weeks, etc. So during operation, cancer is lost, tissue is lost, and also you lose Nagalase activity. That Nagalase goes down by operation. But it's not only by operation. It's also low, increased Nagalase in other diseases like SLE. And I have to make it a little bit short, I think, but you see the difference between SLE and normals. The radiotherapy is also an effect on the Nagalase, yes? And so here you can see that this is the group stage 1, 2, 3, 4. The beginning value, so this is 0.72, and it becomes 0.39 after the radiotherapy, and that's class 1, and then the highest class, for example, 5.16, and it becomes 3.14 after radiotherapy. So these people, Dr. Reddy et al., this Nagalase could serve as a diagnostic and prognostic index that might allow the oncologist to design the dose and the nature of the treatment. So that is important to know. What kind of therapy you use, it doesn't matter so much. As long as it works, Nagalase goes down. And this is the colorectal cancer picture, yes, so which you see in 1 year time is going to normal after weekly injections of 100 nanogram. By this from Yamamoto, of course. And there was nothing seen back. And here we have the 2 other ones, is breast cancer and is prostate cancer, yes, so, but they go quicker. We have read it this morning already, half a year, I would say. So this is just, well, I skip it because we have seen it already. Here I will present you some picture from the laboratory. This is a patient coming here in the beginning, and then you see the Nagelhaas. The second time it's lower, the third time is lower, fourth time, and then it's stabilizing. So this is, you see the date. So we can make reports like this, and if you are attached to the laboratory, you can ask your own connection to the laboratory, and you can see your own results like this easily, which is easy to compare.